The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, and I'm here with one of our associate editors, Greg Feld, talking about the so-called ABCD trial, the alternans before cardioverter defibrillator trial. And this trial addressed one of the most vexing issues we face in cardiology. How do you identify those patients with a low EF who will truly benefit from ICD therapy? So, Greg, can you just tell us a bit about the ABCD trial?
Yes, thank you, Tony. This study from Costantini and al. Followed 566 patients for 2 years, and they actually compared microvolt T-wave alternans versus EP testing in this population to predict who should get an ICD implant. After 2 years of follow-up, the endpoints were a shock event or sudden death, and they showed that the microvolt T-wave alternans met their non-inferiority criteria by statistical analysis compared to the EP testing. Although the 10% margin we felt was a bit potentially wide, the positive predictive value was around 10% for both tests. The negative predictive value, however, was about 95% for both tests.
Yeah, so I guess the first major question they asked was microvolt T-wave alternans equivalent to EP testing? EP testing, of course, is very good at identifying the high-risk patient who will need an ICD, but it's difficult to do, expensive, invasive, and whatnot. Do you think they really established the non-inferiority?
Well, statistically speaking, at 9.5% with microvolt T-wave alternans and 11.1% with the EP testing, with a 10% margin, they didn't actually meet that criteria. But those numbers were relatively comparable clinically, and I think that probably deserves further testing with possibly a narrower margin of non-inferiority. But again, the negative predictive value was very close and would suggest that either test could be used to predict those who may not need an ICD in that low EF population.
Which brings us to the $64 question. Can you use a negative microvolt T-wave alternans test to withhold an ICD from a patient with a low EF?
I think that is one of the goals, although that's slightly problematic even from this data, and that about 4 or 5% of patients might still be missed, those who might benefit if you use one or the other tests alone. The combination of the two, of course, would result in less than probably 1 or 2% being missed, and that's quite good. But the idea of this study was to try to obviate the need for the EP testing, which is invasive and expensive.
Yeah, as I read the paper, it was apparent that the microvolt T-wave alternans enabled you to identify a higher percentage of patients who would actually need the ICD. And the real issue is, are we as a society willing to accept that we'll miss 4 or 5% of patients who could have benefited by withholding the therapy?
Yeah, I agree. Those are the important issues, and having a positive predictive value of only 10% doesn't really help us that much clinically. But the negative predictive value would. If we could get that way down to 1 or 2%, we might be willing to accept that.
Yeah. What about the strategy of taking the patients with a negative microvolt CT, microwave alternans, and then doing EP testing on them to get it down to 1 to 2%?
Well, if indeed the tests were positive, you would probably recommend an ICD. If it were negative and you did EP testing, that would give you that greater accuracy. So I think that may be one alternative for us, is to do the microvolt T-wave alternan test first. If it's positive, apply the ICD, the EP test, depending on the results of that, and then make your decision.
Yeah, well, it's apparent that even despite this very large clinical trial, well done, that we're still searching for answers as to how best to identify those low EF patients who will not benefit by an ICD. For the Genuine Article, I'm Tony DeMaria.
Have a question or comment about a CVN story? Send us an email at cvnfeedback@acc.org.